Thank you so much, and thank you for being here. So the topic of my presentation is hepatitis B reactivation risk with antiretroviral regimens that omit tenofovir, so TDF or TAF. My disclosures. So when we think about managing hepatitis B in the context of HIV infection, there are three main scenarios. We have the situation of someone who has chronic hepatitis B infection, so hepatitis B surface antigen positive, that obviously will require staging of the liver disease, will require preferably dually active antiretroviral therapy regimens that include usually tenofovir, TAF, or TDF, and XTC, which is either 3TC or FTC, and of course management of their contacts and a monitoring plan. Then we have the situation where people are negative for surface antigen, anticore antibodies, anti-surface antibodies, so they are non-immune to hepatitis B. These individuals, of course, require hepatitis B vaccination. We recommend that we assess their response and that we manage a non-response to repeat cycles of vaccination, and if they don't achieve protection, then preferably they should be on regimens containing tenofovir as a form of prophylaxis against hepatitis B acquisition for people that, despite vaccination, cannot make an antibody response, an anti-HBs response. And then monitoring plan, of course, is required. But the topic today for me is to talk about people that have evidence of a past resolved hepatitis B infection. So they are hepatitis B surface antigen negative, but they have anticore antibodies. So how do we deal with this particular scenario in an era when we may want to switch to antiretroviral treatment regimens that do not include hepatitis B active drugs? So we want to complete the workup, and we'll discuss that. We want to assess the risk of hepatitis B reactivation. Once they switch off the hepatitis B active drugs, we want to balance risk and benefit of actually switching, right? And of course, again, we need to set in place a monitoring plan. So let's just think about this from a sort of really basic, if you like, virus-host interaction. So first of all, from the virus perspective, why is it that people with a resolved hepatitis B infection can reactivate the virus? Of course, it is because the virus persists. This is a different form of persistence compared to what we see with HIV, because the really sort of form of proper persistence for hepatitis B is the formation of this mini chromosome that we call the covalently closed circular DNA, cccDNA, inside the nucleus. I don't think it's possible to point right now. Inside the nucleus of infected cells. So the virus forms this mini chromosome, which is the transcriptional engine, and that will persist if the infection resolves, and therefore there is always a risk that reactivation may occur because of resumption of activity. Now, this expression of the virus is under immunological control. So the other aspect is, of course, the immunoresponse to the virus. The immunoresponse to hepatitis B is a very complex scenario, which includes both innate responses and adaptive responses. Among the innate responses, very important role of NK cells, and in the adaptive responses, we now understand that both T cells and B cells play a crucial role in controlling hepatitis B expression from the liver. So you can see how the virus, the immune response interact, determining, therefore, what happens in terms of hepatitis B replication and potentiality for liver disease. But let's take another step back and let's think about people who have a surface antigen. What happens to people with HIV when they start antiretroviral therapy? This is a very interesting field because it's different from what we see in people without HIV. So this is a recent study from Thailand where they had 97, Thailand and Malaysia, 97 people who were naive to treatment, had both HIV and hepatitis B. The majority, so they were surface antigen positive. The majority had also E antigen, high levels of surface antigen, high levels of a bDNA pre-ART. You can see that the median CD4 count here was 240 cells. Let's just keep that in mind for a second. What happens when they start hepatitis B active triple ART, so tenofovir plus XTC plus a third agent, usually in this case efavirenz or an integrase inhibitor, is that 22% lose the surface antigen after a median of 6 months of follow-up. Is this a surprise? No, we have seen this in other studies where anything between 13, 18, 20%, depending on the population, lost the surface antigen when they started antiretroviral therapy. This is different from what happens outside of the HIV field because we don't see this frequent loss of surface antigen when we start tenofovir in someone with hepatitis B mono infection. What's happening here is that, of course, we are boosting the immune response in people to a level that achieves control of the infection. Now, we had already understood this in other studies, but what's new about this study is that TAF seems to have an advantage over TDF, in this case, in inducing the loss of surface antigen. So an interesting study, an interesting observation that needs, of course, confirmation in other cohorts. The other aspect, going back to people who don't have any immunity and need to be vaccinated, is the field of, the responses to vaccination. Traditionally, it's very hard to induce a good immune response to hepatitis B vaccination using old-style vaccines, such as those that use alum. Alum is one of the oldest adjuvants. It was introduced in 1926 and is still part of vaccines such as Engerix, for example. So conventional hepatitis B vaccines have this type of adjuvant. But more recent adjuvants are more active in terms of promoting an immune response. So, for example, we have seen data on the use of this new vaccine known as Epislav B that contains a TLR9-like agonist adjuvant that is really a potent inducer of immune response. And what we have seen is that if you give 3 doses of this vaccine in people with HIV who are vaccine naive, 100% make an anti-HBs response. We've never seen this kind of responses before. If you give them to people who did not respond previously to conventional vaccines, again, after 3 doses, 99% make a response. So you see how you can really help the immune response in people with HIV in fighting hepatitis B. But let's go back to reactivation. So what do we mean by reactivation here? This is virological reactivation. So it's confirmed detection of surface antigen and or hepatitis B DNA, whereas before they were not detectable. And it has to be confirmed, of course. This is the definition of reactivation in people with a past infection. It does not require a rise in ALT to meet the definition of reactivation. The hepatic flare, of course, has its own definition. The guidelines define them according to what you see on the slide, based on the degree of increase of the ALT, of the transaminase. It could be just a biochemical flare, so asymptomatic laboratory flare, or it could be accompanied by an acute hepatitis, by jaundice, or even lead to acute liver failure. So who is at risk of hepatitis B reactivation in general? Is people who receive agents that modify the immune response. We have seen how important the immune response is. Well, if you modify the immune response or reduce immune response, you can trigger hepatitis B reactivation in this context. And of course, the field of application of monoclonal antibodies, for example, checkpoint inhibitors, rituximabs, and so forth, is expanding, ever expanding. You see how many conditions are listed there. And we need to keep that in mind when we monitor our patients with HIV, because in their lifetime, at some point, they may require this type of interventions. So, How is the risk classified? This is outside of HIV in general. It's classified as a low risk, moderate risk, or high risk. If you're interested in the details of this classification, please refer to the reference, these are the guidelines from the American Association of Gastroenterology, and they've just been released a couple of weeks ago. They've been updated. And you see the list there. You don't see HIV in there, right? You don't see taking away hepatitis B active agents from HIV. That's because the risk had not been really quantified. And we didn't know whether it was high, it was moderate, it was low risk. Note that, for example, the risk associated with giving direct acting antivirals in someone with hepatitis C and a past resolved hepatitis B has been quantified. There is enough evidence there to say that there is a risk, although it's usually less than 1%. So it's a low risk. What do the guidelines say about what to do in these scenarios? Well, if the risk is high, so you're using rituximab, then you really should use antiviral therapy as prophylaxis. Okay, so that is absolutely well established. Doesn't always happen, which is really surprising, but it is the recommendation. Moderate risk, treat or monitor, and the guidelines come down in favor of actually giving prophylaxis. If the risk is low, you can decide to monitor or treat, and this can be a conversation had also that you may want to have with the patient. But what about our patients with HIV and resolved hepatitis B? Where do we place them in this scenario? I should also add that when the guidelines talk about treatment prophylactically, they refer to agents with a high barrier. So they are referring to tenofovir or entecavir. They are not talking about lamivudine as prophylaxis. So what is the risk? The risk in people with HIV and a resolved hepatitis B, when you take away hepatitis B active drugs, has not been very well quantified because we don't have enough studies, surprisingly, but we don't have enough evidence. What we do have, it suffers from variability in the definition of reactivation. Someone just wants to talk about ILT flares, but that's not the way we define reactivation in this context. And also, monitoring methodologies vary. So different type of assays, different type of strategies. So it's very hard to make sense of the evidence. Also, a lot of the data sets, unfortunately, tell you that, yes, they took away tenofovir, and maybe some people continued lamivudine, but they don't tell you how many. They don't present the data separating those that continued lamivudine or didn't continue lamivudine, so you cannot really understand the risk. There is one piece of evidence. This is a study that was presented at this conference last year by Fox et al. From VIF, looking at the risk of hepatitis B reactivation defined as we are defining it in people who switched to dolutegravir and lamivudine and had anticore positivity. They were followed, they were monitored within this study, in this analysis, and over 144 weeks of dolutegravir plus 3TC, they did not see any reactivation among 71 participants. What can we conclude? Well, we think lamivudine has some prophylactic activity, but remember that it's not the preferred agent if your risk is moderate or high. So the evidence base, I think you can see it in poster 66, or you may have heard me presenting on our first day here, but we tried to screen the literature, we tried to see what's available. We came down to a number of studies. We had to exclude those that had used non-standard methodologies for assessing reactivation because we want to be practical. We want to talk about things that we can all do in clinical practice, so we cannot use exoteric tests which are not available to everybody. And also we need to know if people continued or not lamivudine. So once you've done all this screening, you end up with 4 cohort studies and 7 case reports. And the key findings, please see the poster for more details about these reports. But essentially what we found was 99 reactivations among about 6,000 people, giving us a 1.6% reactivation risk, which will pose someone with HIV into the moderate category between 1 and 10%. But please take this with a pinch of salt because we really need more, better evidence to define this risk. Also, the risk is not uniform. There are a number of risk factors for reactivation that will push the risk higher rather, or if not present, will make it lower. The risk factors are, of course, a low CD4 count, a low nadir CD4 count below 100, having HIV viremia, having HBV DNA detectable before you switch to Hep B inactive agents, also having, of course, any of the other reasons of immunosuppression that we listed before, or having advanced chronic liver disease or poorly controlled diabetes. So these are all risk factors. So we can put all of that in our mind. But what we know is that reactivations can occur across the range of CD4 counts. You don't need to have low CD4 counts to reactivate. You can be virologically suppressed and reactivate. If you have anti-HBs, you will have a degree of protection, but it's not absolute. And you may have ALT increases associated with the reactivation, and you can have also a severe hepatic flare. But in the literature, we were not able to find anybody who had acute liver failure or needed transplantation or died. Certainly because they were generally managed by reintroducing the hepatitis B active agents. And the good news also was that what we saw, particularly in the case reports, is that despite having quite severe reactivations, very high HBV DNA levels and so forth, once the Hep B active agents were reintroduced, people controlled the infection and usually lost the surface antigen. So they reverted back to their previous profile. Again, please take this, this is limited evidence, right? So the quality is low, moderate in some cases. So this is a case report, which we did not include because it's just been published, and is I just pointed out to you because it's got some interesting aspects. This is a 50-year-old man in Japan who was known to have had acute hepatitis B infection 15 years earlier. Then he received for about 14 years a tenofovir and FTC-based regimen. He made a good CD4 count, was 512 in the most recent measurements. And for a number of reasons of convenience and so forth, there was a decision to switch to gabapentin long-acting. This is a nice article because they do discuss the risk-benefit analysis that they did prior to the switch. So they said, look, we actually thought he had not developed chronic infection when he had been infected 15 years earlier. He had been repeatedly surface antigen and Hep B DNA negative during over more than 10 years, of course, while he was on tenofovir and FTC, and he had initially made an anti-HBs response, although they report an anti-HBs response which was only about 20 or so, 21 to 19, and in fact, it was lost after year 6. So this was someone who had made an anti-HBs and then lost it. What happened is switched to cabrylpivar in LA, and as you can see from the table, had a big reactivation, which, however, was only a biochemical hepatitis. It was asymptomatic and was switched to BF-TAF. Pity we don't have the follow-up for this case, but it just goes to show that you can have a good CD4 count, you can even have a past history of anti-HBs, and yet you can still reactivate. So what is the managing strategy that we can propose? First of all, I would say, let's collect better evidence. But for the moment, what can we do? I think on the basis of the test results, what we recommend is that if the anticore is the only marker positive, we always recommend also testing for anti-HBe antibodies, so antibodies against the E antigen as a further marker of past infection, because in that way, it will reduce at least the risk that you may be looking at a false positive core antibody test. And about 40-45% of people that are surface negative, antigen negative, anti-HBs negative, but anticore positive will have anti-E. And then we recommend giving them a dose of a standard vaccine to see and measure responses after 2 weeks to see if you can induce an anamnestic response just to prove that you had a past infection. If they don't make an anamnestic response, go ahead and vaccinate. There is little risk in vaccination, so go ahead, vaccinate, and then they can reconverge with those in whom you have anti-HBs, you have anti-HBe, so you know there is a past infection for sure. And what you do, you evaluate the risk, you do the risk benefit assessment, and you adopt a monitoring plan. The monitoring plan is important. We don't have the details of how to monitor, but it's important to put it in place and must include surface antigen and DNA done frequently enough. So, to conclude, a resolved hepatitis B infection does not preclude switching away from a tenofovir-based regimen, but it does require a risk assessment. The risk assessment should be done pre-switch and then ongoing post-switch, because things happen, right, in life. People may need other interventions and so forth. Anti-HBs protects, but is not an absolute protection, so don't rely on those as the, reassurance factor. 3TC, some protection, but again, is not the preferred agent for prophylaxis if the risk is moderate or high. The monitoring plan we discussed is crucial, surface antigen and HBV DNA, as well as your routine transaminases. And as I said, please, let's collect better quality evidence. Thank you.